You're watching Beyond Market, where we bring you up to speed on development outcomes in Africa. I'm Kenneth Igbomo, and thank you so much for joining me on the show today. Coming up on today's show, we'll look at how Africa is bracing up with the COVID-19 pandemic and how we can redefine the intensive care unit system management in Nigeria, in Africa. You can join the conversation on social media and let me know what you think about the topics we discussed. The hashtag to use is Beyond Market. You can also hit me up at Kenneth Igbomo. Now, the COVID-19 pandemic is stretching health systems across Africa with over 400,000 confirmed cases on the continent and just over 10,000 deaths, with many patients in intensive care. How can the continent redefine better models to get better outcomes for healthcare? Dr. Babaseyi Oyesola, consultant in anesthesia and critical care, joins me now for this discussion. Thank you so much for your time today, Dr. Babaseyi. And I would like to understand, looking at how overstretched Africa's health systems are and how the COVID-19 is playing out, I'd like to get your thoughts as a medical professional.
Good afternoon, everyone. Anesthesia and critical care has suddenly come into focus because of the COVID pandemic. But that's to say that critical care as a part of that is actually very important in medicine generally. It just so happens that it has come into sharp focus because of COVID.
Now, but let's look at how we can find creative ways to cater to the rising numbers of patients that we're looking at, and what creative ways can we put into place?
Creative ways is a very difficult thing to apply in medicine. As you can imagine, it is not a subject of creativity, but it can lend itself sometimes to a bit of innovation in the area. There have been devices that have assisted us in helping to make critical care more accessible, given that there are so few of them in Nigeria and certainly in Africa. We do not have enough intensive care units. We do not have enough intensive care personnel, nor do we have enough people that are trained in that area. So telemedicine is one of the best of all alternatives. It actually allows us to use personnel abroad, personnel that are not geographically close, and it allows us to communicate information about patients to distant but knowledgeable and expert arenas. And this includes people who already practice intensive care anywhere else in the world. So long as there is internet access and the reach is adequate, we can use both video and voice. And this is perhaps the most creative way to apply technology right now to the use of treating people in critical care.
Listening to you speak, it kind of speaks to the fact that we need a very holistic, approach in getting the healthcare ecosystem to get better outcomes. Because when you look at it, before even patients get to intensive care, I'm sure along the way there are other areas of interventions that could have come in place to prevent them getting to the stage where they need to be at the ICU.
Yes, that is correct. Indeed, 80% of all patients who are tested positive with the coronavirus, for example, are either asymptomatic or have very, very mild symptoms. A lot of those that even need to go to hospital, the rest of the 19 to 20% that actually do need to go to hospital for treatment, only a small proportion of them end up in intensive care. So it is important to have other modalities of respiratory support, especially because in COVID's case, it's actually a respiratory illness. For that reason, if you do not have well-developed oxygen supplies, if you do not have well-developed non-invasive ventilation, when we say non-invasive, we mean non-ventilator-based technology that will allow us to add oxygen therapy to the module of treatment. Now, if we don't develop those areas, we will have limited availability of therapeutic options.
Looking at critical care now, let's look at some of the recent updates that we've seen, come on board now. We've seen for treating patients who are critically ill with COVID-19, we've seen that story about the dexamethasone drug coming up, the steroid that it's supposed to help out with patients. I'd like to know how looking at in the nature of the work that you do, how we can get even more, and I can understand that you also been dealing with quite a number of critical cases in there. I'm trying to understand how we can get better, results from there, and also what with the recent avenue and research, is it available to help the work that you're doing?
Yes, there's plenty of dexamethasone around. If you look at the literature, this study came out of Oxford. it was quite a groundbreaking one. The study was quite a groundbreaking one because we know that dexamethasone as a steroid anti-inflammatory has those effects, but more importantly, because it is inexpensive. Now, we don't need further research to determine whether dexamethasone is useful or not, because dexamethasone has been used successfully and it has reduced mortality, that is the death rates of patients, by 30%. I think the actual figure is about 32%, which is a big, big number, considering that every time one life is saved for that patient and for that family, that's 100%. So dexamethasone for sure has been demonstrated the ability, and we've moved slightly away now from using ventilators. There are times when you have no choice. The patient is too sick to do without a ventilator and you have to use it. Our experience here in Nigeria, all the way from non-invasive ventilation, where we just use face masks with oxygen and a ventilator if necessary, we've moved even to ECMO in the area of extracorporeal membrane oxygen removal and oxygenation. So we have a position where we have innovative ways, but limited supply of those innovative ways in Nigeria and indeed in Africa in general.
Earlier on, you alluded to the fact that we don't have enough capacity in intensive care to deal with the demand that is on ground as it plays out. But I'm trying to understand avenues in which we can also build that capacity, and also because we're facing an existential threat here with this virus, and I'm trying to understand how we can quickly ramp up that capacity, in terms of personnel skill and even equipment.
What would happen if we're going to do it rapidly is to import such skills and to accelerate training. But unfortunately, we are starting from a very, very low, poorly developed base. It's so poorly developed now that the existing units, which would have been built on, are not robust enough to build on rapidly. So perhaps the fastest and the most important way would be to educate and train people via, again, telemedical approaches, and to get people in to see the few centers and train trainers to further grow the knowledge base as rapidly as possible.
All right, now, but then there's the issue about cost. I'm trying to understand what it will cost to get proper ICU management in a place like Nigeria, for example.
ICU is expensive, and it doesn't matter where in the world you go. The intensive care unit can be perhaps the most expensive place to be in any hospital, anywhere in the world. Now, having said that, the ways in which the cost of providing critical care, intensive care, has been mitigated include insurance, and I have to say A3C is in the process of looking at collaborations with insurance companies at the moment. It is also possible for philanthropy, where government does not have enough funding to provide critical care to the population free of charge, to use philanthropy. Corporate social responsibility has been very good, and I think we've had quite a good response from the banks, the oil and gas sector, and indeed the telecoms in this part of the world. So it's really a matter of cost. Once you can pay enough people who are knowledgeable and skilled enough to do the job, a very difficult job at that, then you can actually ramp up very quickly the both industrial and non-industrial base for supplying medical services.
Yeah, but for the medical equipment, though, how readily available are they, and how easy is it to procure at a time like this, especially when we're dealing with a pandemic where borders are closed?
That's a very good question. It's not just the closure of the borders that has caused the difficulty in acquiring this equipment, but because the demand for such equipment is high all over the world. Not only has it become in relatively short supply, all this equipment has also become relatively expensive. The stuff that was not expensive before has become even more so. So if critical care is expensive to start with, and we do not have enough equipment in Nigeria, indeed in Africa, ourselves, and we are not in a position to manufacture this equipment, then we are purely dependent on importation. In due course, I can expect that Nigeria, indeed Africa, will begin to manufacture a good range of this equipment. This will probably be a good pointer to ensure that we begin to look at that sector for manufacture.
All right, but in looking at how we are looking to try to redefine the intensive care management, I'm trying to understand how organizations like yours are going beyond the norm.
A3C is a group of independent specialist private providers of critical care services. And what we have done is to begin to look at ways of taking critical care to the patients and working as a group to cover more than one hospital base, so that as a group of specialists, rather than sit in one hospital, we use a combination of telemedicine, training, and linking up with other international institutions. The way to mitigate the biggest problem, though, of cost is, first of all, not to try and make every hospital buy intensive care equipment. We're encouraging hospitals to pool resources so that they can actually use one critical care unit to serve more than one place. And as soon as we're able to get the cooperation of insurance companies and similar healthcare maintenance organizations, I'm sure that we can help to drive the cost of critical care down. In those various ways, I think we're doing our best to see how we can improve the reach of critical care and make it more accessible to as many more people as possible.
I'm trying to look at the spread now. Yes, definitely we can sit in Lagos and have all the services in here. But for people who live more in the hinterlands and people who live in rural communities, how can we ensure that we can get that spread?
Well, the truth of the matter is you can't. You can't actually get critical care developed to the point where you can deliver it to every nook and cranny of any part of the world, to be honest. There are places in the UK and in the US where we've all worked in the past, where if you need intensive care, you will need to be shipped out of the local hospital and shipped to a central place. Intensive care, critical care is just way too expensive to build a critical care unit, equip it and staff it in every single part of the country. But we can have regional centers that are readily accessible by various means of transport, and that is what we're trying to achieve.
But in trying to ensure that quality, looking at what is available here in this part of the world, would you say the level of sophistication is comparable to what we have elsewhere?
The truth of the matter in Nigeria, and I'm sure in other parts of Africa, is that we have pockets of excellence. For example, there are places in Nigeria where, at least one place I know, where you can use things like ECMO. ECMO is perhaps the most advanced form of therapy that can be used in patients who have severe respiratory compromise in COVID. But then ECMO is expensive, the equipment is difficult to get, the consumables are even more expensive, and the training that you need for people to do it is quite a lot. So what I'm trying to say is this: if you have high-level technology in a few centers, and you have means of transporting patients that need that level of care to those centers, it's a much more pragmatic and much more realistic approach to providing the quality of care that these patients need. So quality-wise, it might be difficult to provide across the board, but if we have specialist regional centers that are developed to the extent that they can provide them, and we're able to transport patients in a well-structured network, I think we can solve the problem.
All right, but in looking at models that we can explore to make this more available and even in the quality that we need, I'd like to also look at if we can explore models like collaboration, with global organizations to help replicate these pockets of excellence like you rightly mentioned.
Yes, and again, going back to telemedicine, that is probably the most cost-effective way of achieving what you have just described. It is important for us to be able to form these networks. The internet has become quite a useful tool in that respect. And I assure you, a lot of information is changing hands on a daily basis from different parts of the world. And Africa, certainly we in Nigeria have benefited from that. The internet access in this country has improved significantly over the last 5 to 10 years, to the extent now that we're able to stream. And as you can see, I'm streaming this broadcast itself.
All right, but I'm trying to also look at what role the private sector can play in all of this. You know, definitely quite a lot of work needs to be done. I understand even in Nigeria here, we're seeing the private sector coming together to try and put together primary health centers in all the 774 local governments across Nigeria. But I'd like to hear your thoughts on this scheme and how laudable you think it is and how much we can replicate this as well.
Yes, the private sector is a big thing, but here's the truth. The vast majority of people who require healthcare in this part of the world have to pay out of pocket. Now, nowhere in the world does it happen that people pay out of pocket for healthcare, and indeed the best healthcare. The private sector is trying to play its part. But I don't know about the private sector getting too deeply involved in primary care if there is no support from government. But private industry, I have to say, is where the country is going. It has worked everywhere else. It has worked in every other sector, the telecommunications sector, the airlines, name it. Any really successful thing, certainly here in Nigeria, has been because the private sector has taken it up. So I'm imagining that the same thing is going to happen in healthcare. And we as a private group, private organization, are doing our best to bring excellence as well as good care to the critical care sector of healthcare.
It speaks to the immense amount of work that needs to be done, especially around health insurance, to ensure that we're getting, comparable, outcomes when it comes to delivering healthcare. And I'd like to speak on, for you as a medical professional, and some lapses you've seen in the insurance, current insurance schemes, and what areas you think might need some tweaking.
The health insurance scheme in Nigeria is largely new. It is not yet particularly well developed, but it is growing. And as we develop scale, I imagine that the premiums will come down. But here is still the problem, capacity. It's one thing for the insurance companies to want to offer certain kinds of care, but if the care they can offer is not supported by adequate resources, both human and otherwise, then it becomes difficult. So if indeed we're going to be successful along those lines, then it is going to take time. The insurance companies are beginning to realize that there can be value, but the insurance companies need personnel, they need hospitals, they need equipment that is available locally to provide care. So when they take premiums, they'll be able to deliver on the care. So again, it just comes back to capacity. I don't think the insurance companies themselves have much responsibility on that level, but if they have a commitment to healthcare, I would imagine that they might even start to invest in hospitals. It is my understanding that some insurance companies are beginning to look at direct and indirect investment in hospitals in Nigeria. So I can imagine that over the next few years, we're going to start seeing some changes.
Yeah, because at the heart of all this is the models of financing that we're looking at, and how we can get that cover the cost, whether it's of the healthcare of the patients, or even ensuring that we have equipment available in critical areas where people can have access to.
Yes, I agree with you entirely. I mean, ultimately, if you don't have the money to do it, then you can't. But there are creative ways. We've talked about the corporate social companies and other industry can use to contribute. We've talked about raising funds by philanthropic means. And certainly, if pooled investments, and when I say pooled investments, I mean the sort of thing that comes from a lot of people paying small premiums with the knowledge that a very small proportion of them will claim. That is how insurance works, after all. So it is really just a matter of scale, but we must never really forget that you need to invest in the infrastructure, the resources that will deliver, that can and will deliver the care that is required. So as much as we raise the money, we also need to build capacity.
All right, when you look at how the COVID-19 pandemic has played out in Africa and Nigeria specifically, luckily we're not seeing the kind of numbers that we're seeing elsewhere. I know definitely it might not speak to the amount of quality of healthcare that we have in there, but it's more or less a stroke of luck. But I'm also trying to understand from your experience, in dealing with some of these patients and and how things are playing out. What hope do you have in how Africa or Nigeria or Africa as a whole we can come out of this on the other side looking better?
Well, first of all, it's important for me to say that we do not appear to have the same severity of illness. We seem to have the numbers, but we don't appear to have the same severity of illness. So the issue of trying to flatten the curve has not yet become apparent to us. How are we going to come out looking good on the other side? Honestly, I'm not sure anybody can predict how Africa is going to come out on the other side, just as we couldn't predict the second wave that is ongoing in the US at the moment. However, I think it is important for us to accept that we have limited resources compared with other parts of the world. And if we are going to go anywhere with this, we're just going to have to continue to invest in the resources that are required. Do I think we're going to have the same severity eventually? I don't know. I hope not, but I don't think anybody knows.
All right, then. Thank you so much for your time today on the show. Dr. Babaseyi is a consultant in anesthesia and critical care. And that's it on Beyond Markets for today. And thank you so much for being a part of the show. Remember, you can watch Beyond Markets at 5 p.m. West Africa time daily and have access to all episodes of Beyond Markets on our website. That's at CNBC Africa.com. From me and the team, enjoy the rest of your day.